Module 12 is on musculoskeletal disorders. So the first thing we're going to talk about is a review of the anatomy and physiology of the musculoskeletal system. So the musculoskeletal system is comprised of bones, muscles, joints, tendons, and ligaments. While children are still growing, bones are cartilaginous and growth plates are open. So different parts of the bones that we need to know. The physis is the segment of bone that's responsible for lengthening. It's also called the growth plate. The epiphysis is the very end of the long bones. So if you're looking at the diagrams on your slide, it's just, you can see where it's pointing to the very end of the bone. The metaphysis is the wide part of long bones, so the part right next to the epiphysis. The diaphysis is the shaft or the long part of the bone, and the periosteum is the sheath that's covering the bones, and it helps to supply blood and nutrients to the bones. An immature skeleton, or basically when we have children, their skeletons are immature. It can actually be a little advantageous for them because they have an increased resiliency to stress. The periosteum is thicker in a child's bone, so more blood supply going to it because it is growing. They have an increased potential to remodel and shorter healing times. So if they break a bone, usually they heal faster and they have shorter immobilization times. So they would need to be in a cast for a shorter period of time. And they also have the presence of the growth plate. So if they do break a bone or if it's misaligned, these misaligned fragments may become solid sooner than in an adult. So this can be good for the child because it of course heals quicker. It can also be bad if we wait too long for treatment and then the bone becomes solid in a misaligned way that we don't want it to be in, and then the bone may be abnormal from there on out. If we are assessing a child with a musculoskeletal disorder, we can of course ask them health history questions that have to do with whatever signs and symptoms they're coming in with. We can do, of course, their height and weight, inspection and palpation of, say, the affected extremity. Say if they think they broke their leg, we can inspect and palpate it. Range of motion maneuvers. So, for example, can they move their leg in certain directions that we would expect them to be able to do, like abducting their hip or extending their knee. We can do lab tests and, of course, diagnostic imaging, things like x-rays, CT scans, MRIs. Injury pattern and growing bones. So when we're talking about children with bones that are not yet mature, their bones actually tend to bow rather than break. So if they have some sort of injury or trauma or compressive force, the bone may actually bow rather than breaking like it would in an adult. Talking about compressive force, one of the types of fractures we're going to talk about that's very common in children is called a buccal fracture that is caused by compressive force on it. So you can think of the bone sort of buckling underneath the force. We'll talk more about that later. And in children, also, the ligaments and tendons are actually stronger than their immature bones. So their bone is more likely to be injured than, say, their ligament and or tendon. So they're more likely to either break a bone or bow the bone or have some sort of injury to the bone rather than, for example, like tearing a ligament. So emergent and initial nursing care, just very vague and sort of generic care that we can do for a child with a musculoskeletal injury. One of the things is PRICE. So that stands for protect, rest, ice, compression, and elevation. So say a child comes in with a broken leg, we want to protect them from injuring it any further. So something like putting a splint on it or a brace or whatever is ordered. Rest, so keeping them on bed rest. You can apply ice. Compression can be something like an ace bandage, and then elevation, like propping it on a pillow. We also want to be doing neurovascular checks, so things like checking for sensation and the affected extremity, if it's an extremity, checking for things like cap refill, pulses, can they move their extremity or whatever it is that is hurt. We also want to promote natural alignment, so we don't want to have them laying in the bed, say on their side on their broken leg. If they have a splint or a brace or a cast, we want to make sure that that's intact. We can also teach them how to use things like crutches or a wheelchair or whatever they need. Educate them and maintain activity level precautions. For example, if they're on bed rest. We can, of course, give them pain medication and then use non-pharmacological pain methods as well, so things like distraction. We can monitor for fever or foul odor coming from, say, an incision where they had surgery, or even something like a cast, if there's any signs of infection. We can consult interdisciplinary specialties, so extremely common to have physical therapy or occupational therapy consulted on someone with a musculoskeletal injury. And we can, of course, assist them with their activities of daily living, like helping them go to the bathroom or eating, and then making sure that they are aware of their follow-up visits. So starting to talk about fractures, one of the types of fractures that a child can have is a physial injury. So remember, the physis is the growth plate. So it's basically a fracture that's at or around the growth plate. So this can disrupt the growth of the bone. So there is a chance that if a child does have a fracture right at their growth plate, it can maybe stop growth of the bone or can cause some sort of deformities. The deformities can be caused because if the injury is not at the physis but near it, it can actually do the opposite and stimulate bone growth. So these can be some of the instances where some people, for example, may have like one femur that's longer than the other, or tibia, so one of their legs appears longer than the other. Could also be from a hip problem, but these things can also happen from physical injuries. The younger the child is, the better the remodeling, and it heals very quickly. So remodeling, if you don't know what that is basically where bone tissue is removed and new is formed. So where there is an injury, it's basically just the healing of the bone. Physical injuries are actually pretty common injuries, about 15 to 30% of all fractures. So in not all instances does the person have like growth arrest where it's not going to grow properly, or stimulated bone growth, but it is a chance that this could happen. The incidence of all fractures, so not just physical injuries, but all fractures in general, is pretty high. So the chance for fracture in boys is 42% and girls 27%. Commonly involved sites for children. The distal radius or the wrist accounts for about 50% of injuries. And also the clavicle, hand, elbow, and tibia are common in children. So continuing with fractures, a torus fracture is also called a buccal fracture, and this is the one I mentioned before. It's where the bone bends and buckles, but it does not actually break. It commonly occurs in the radius or the ulna or both. This fracture occurs only in children because their bones are softer than those of adults. This type of fracture, if anyone's had a child or heard of another child that they know, that sometimes it's not diagnosed until days after the injury occurs, because sometimes it's not as painful and it's not as obvious that the child has actually broken their arm. But if you're looking at the top two pictures of the x-ray and then the drawing of the buccal fracture, if you're looking at that, you can see that they call it a fracture, which is sort of confusing, but there's not an actual break. So like on the x-ray, you can barely see anything there at all. There's like a little mark. And then on the drawing, you can see it sort of looks like the bone is like smushed down or buckled because of the compressive force that caused it. This one, they usually, again, it's usually the radius and ulna, so they're going to have a short arm cast for 3 to 4 weeks. A short arm cast basically means that it's not going to extend to the upper part of their arm. Green stick fractures you may or may not have learned about already, but adults can get these sort of fractures also. This one's an incomplete fracture of a long bone, it's commonly in the mid shaft of the bone. So not on the ends of the bone, but in the shaft or the mid diaphyseal area. If it's non-displaced, meaning that it's still aligned, then they can just have a short arm cast for about 4 weeks and then a splint for about 2 weeks. If it is displaced, meaning is it totally out of alignment, where they either had to have the provider come in and reset the bone back in place, or they had to go to surgery to put it back in alignment, then they're going to need the long arm cast, which is going to go like the full length of their arm, including the upper arm. A distal radius fracture is often just called a wrist fracture because of where it is at the very end of the radius near the wrist area. This one for non-displaced fractures, meaning they're in alignment, they're given a short arm cast for about 3 to 6 weeks. The length of time depends on numerous things, but one of the reasons can be how old is the child. So the younger the child is going to need a shorter time in a cast. Elbow fractures are actually very common in children. 10 to 12% of pediatric fractures are of the elbow. Most of them are called supracondylar fractures. These are the most common. So this one is the top right picture. It affects the weakest part of the elbow joint where the humerus flattens and flares out. This one, they can have the potential for vascular compromise, so we want to make sure that we're checking the 5 Ps. So the 5 Ps are pain, pulse, pallor, paresthesia, and paralysis. If the pulse is compromised, it will need to be reduced. Of course, that's going to be done by a provider. And we need to check nerve function in hand. So that can be as simple as, can they move their hand in all of the different ways that we would expect them to be? Do they have sensation and things like that? Another type of elbow fracture is called lateral condylar. It's the most common physial elbow injury. So this is a growth plate injury. It's often caused by fouche, which stands for fall on outstretched hands. So if you can picture a child falling basically with their hands out in front of them. Most of these lateral condylar elbow fractures are displaced and require pinning, meaning that they're going to have surgery to have pins inserted into this area of the elbow. And since it is a growth plate injury, they may have growth arrest or non-union. Non-union meaning basically pieces of the bone don't join back together like we would like them to. Another type is a medial condylar elbow fracture. This one's common with baseball pitchers. That's caused by overuse and repetitive motion from pitching. This one, though, has more conservative treatment where they're usually just wearing a long arm splint or a cast. Over time, though, they may have stiffening, ulnar nerve injury, and non-union as well. Clavicle fractures, as you probably know from OB, are the most common birth injury. But not only babies can fracture their clavicle, also older children or adults can also. It could be from the fall on outstretched hands, a fall on the shoulder, or direct trauma to the clavicle area. A lot of times from things like wrecking on bicycles. This one, you can a lot of times see an obvious deformity coming up from the shoulder area. In an infant, you may not see this at all, and it may be missed in infants until a callus formation causes an actual visible bump on their shoulder area. If it's an older child and they do have a clavicle injury, they could need cervical intervention. Usually that's if you do see the actual bone sort of pushing the skin up, or if the bone is broken into many like little pieces. But most of the time, clavicle injuries are treated with a simple sling. So for an older child, just a normal sort of arm sling that you may have seen someone wear. So no casting is needed. It just helps to reduce pain because having the arm sort of across the body is less painful, and it also warns others that this person is injured, so don't like bump into them. For babies, one way to treat it is like this picture on your slide of this baby that has this sort of little makeshift sling. This one's actually a product that hospitals can buy, but it's really honestly just made out of like gauze. We also in the hospital would sometimes use like a long sleeve onesie that's a little bit too big for the baby, and basically using the long sleeves of it as a sling, or just even simply swaddling the baby with their arm sort of across their chest or their upper abdomen area. For an older child, they can't play any contact sports for 6 weeks, but they can usually take their sling off after about 4 weeks. They may still have a bump even after fully healing. So they may have formed a callus and you may see a bump on their clavicle area. Tibia fractures. So tibia fractures, so the lower part of the leg, the bottom picture there, typically occurs when the foot is twisted during a fall. It requires a lot of force to break the tibia because it's a fairly large bone, so it's rarely displaced, but not impossible. Usually with these, we splint them for 24 to 48 hours before putting a cast on to allow for the leg to swell, and then leave the cast on for about 6 to 8 weeks. Toddler fractures is sort of a vague sort of category here, but this applies to children that are younger than 2 who are learning to walk. So sometimes this is one where no specific injury is noted most of the time, but the child may start to refuse to walk or bear any weight on their leg. With this one, we also should always rule out abuse. So if it's a spiral fracture, that could be a common signifier of abuse. So we want to examine for soft tissue injury to other areas of the body. So do they have any like bruises or anything on their butt, on their legs, on their head, or their neck? This one, they usually have a long leg cast for about 3 to 4 weeks, but it heals pretty quickly in about 5 to 8 weeks. Femur fractures are usually a diaphyseal fracture, so basically the long shaft part of the femur, and it's typically caused by trauma. So things like car accidents, sports, falls. We want to rule out abuse if we see a femur fracture in an infant or a toddler, especially if it's a spiral femur fracture, especially because these children either can't walk or they have just learned to walk, and it takes a lot of force to break a femur. So if there's any sort of suspicion around it, it should be investigated. So treatment for femur fractures, one thing that could possibly be needed is traction before or even sometimes after the child has surgery for their fracture. So if the bone needs to be reduced, they could be in skin traction. So this picture of the drawing of A and possibly B could be skin traction as well. I can't really see that well under those child's bandages. But basically, there's something attached to the child's skin, usually with some sort of wrapping. So it helps basically hold the position of the bone or even help realign the bone until the child has actual surgery. Since with femur fractures, I know these pictures aren't necessarily of femur fractures, but since there are large muscle groups around the femur, there is the potential for muscle spasms while in traction. So if the child is having muscle spasms, which can be quite painful, one of the treatments for that is using IV lorazepam about every 4 to 6 hours as needed. So then the spasms will hopefully subside with the lorazepam. They could also be in skeletal traction. So skeletal traction would basically be if the child does have pins that are surgically, or they can also be externally placed around the bone. And then the traction is actually connected right to those pins or rods. So if we have a child in traction, things we want to do is make sure that we are maintaining their body in the correct alignment. So typically they're going to be on their back. So we don't want them to be all twisted in the bed so that their bone that we're trying to keep in alignment is not now out of alignment. We also want to assess their pulses frequently, monitor skin integrity, monitor that their weights are hanging freely and not touching the bed frame or the floor. So if you look at the top diagram, you can see that there's weights that are at the end of the bed that are basically help holding this person's leg up in the air. So we want to make sure those weights aren't all tangled up, that they're not on the floor, and that they're not touching the bed frame. For a femur fracture, they could have an ORIF. So an ORIF, or ORIF, basically stands for open reduction internal fixation. So open reduction means that basically they open the person up, like with surgery, to reduce the bone or put it back into place, and they're internally fixating it. So meaning they're putting something like a nail or a rod inside the child's body to fix it into place. There's also external fixation that could be used as well. One of the treatments for femur fractures in toddlers and preschoolers is a Spica cast. So the Spica cast, as you can see in this drawing and this photo, it depends on which bones are broken and the orthopedic surgeon's sort of preference on how it is made specifically. But typically, the leg that has the femur fracture, the Spica cast will go all the way down sort of to the ankle area on that leg. Sometimes some surgeons do it on both legs. Also for another condition that uses this, it may be fully on both legs as well. We'll talk about that later. But sometimes on this, like on the picture on the top, you can see here, that left leg is not fully casted. But the cast does extend up into the abdomen area, possibly all the way up to the nipple line, depending on how big the child is. So as you can see, this sort of cast is probably not fun. So we need to do some things for the child and teach the parents some different things as well. So we need, if they're hospitalized, we're going to turn and reposition the child every 2 to 4 hours while awake. We can also educate the parents to do the same as well. We also want to do neurovascular checks every 2 hours for 24 hours post-op. So things like checking capillary refill and pulses on the baby or toddler's feet. We also want to use 2 fingers along the abdominal area of the cast to make sure that it's not too tight after position changes. So depending on how the orthopedic surgeon puts this cast on, some of the applications will allow you to actually put the diaper up inside the cast, so sort of like the picture on the bottom, where you can tuck it up inside. It's just you're not going to be able to really fasten it inside, but it doesn't really need to be because of the cast sort of holds it in place. This top picture, I can't tell exactly what's going on under the diaper, of course, but sometimes people will put the diaper on and put it up inside the cast, and then also put another diaper on the outside of that, just in case, like as an extra protectant. We would need to protect, though, the cast from urine and feces, so you can do that by using chucks with sort of the absorbent side towards the skin if you can't fit the diaper up in the cast. Also, you can see on this drawing on the bottom where they've put waterproof tape around the edge. So even using something like duct tape as well, any sort of tape that's waterproof to protect the edge of it. Of course, we want to give them pain medication as needed. And also we need to prevent constipation. So with this one, especially if it's a toddler or a preschooler who is walking well and running around, now they obviously can't, so they're going to be immobile. They're also going to be on pain medications, which could cause constipation. So we want to make sure that we're increasing fluids, increasing fiber, and then avoiding types of foods that usually constipate people, things like cheese and milk. So just some general things to know about fracture care. We always want to assess for signs of abuse when we have a fracture in a child, especially if they do have a spiral fracture. We always want to assess sensation, numbness, and tingling of the affected extremity, and also assessing cap refill and color of the affected extremity. We need to educate the patient and family. Things like no running, jumping, or climbing, no bike riding. Of course, this depends sort of on where their broken bone is, but in general, we want them to stay safe and not do anything crazy to re-injure themselves. We want to make sure that they're not inserting anything into the cast. So casts typically get very itchy, and kids want to put things down into them to scratch their skin, but we don't want them to do that because they can cause some type of tissue injury to their skin and an infection. We want to teach them to keep their cast dry. There are waterproof casts now, so depending on what type of cast they have, if it can get wet or not, what they can do to prevent it getting wet. If it's an upper arm break that they have, making sure that they're using their sling or their brace as instructed and keeping it at about the heart level. We don't want them to wear slings in bed at night because of safety issues. For lower extremities, we want them to use their brace, their crutches, and wheelchair as instructed. So basically, so they're not walking on their injury too soon. Clubfoot is a congenital abnormality. It can also be idiopathic and have no known cause or neurogenic. So it may be caused by a syndrome, could be caused by exposure to teratogens, or simply just being malpositioned in the uterus. Family history increases the incidence of this. It actually affects males more often, 2 to 1 more than females. It can be unilateral or bilateral, so it can just affect one foot, or it could also affect both. It also affects the entire lower extremity from the knee down, so while it's called club foot, it also does affect the calf. The calf may actually look smaller, and the actual muscle may be smaller and have less ability to develop muscle strength. The actual foot may actually be smaller, and it's fixed in this really rigid plantar flexed and pronated position. So if you're looking at these, like this bottom picture of that baby's right foot, you can see it's sort of turned inward and you can't stretch it back into its normal or neutral position like the other foot is in. So no matter what you do, it literally will not go back into the correct position. So treatment for clubfoot, there's both non-surgical and surgical treatments. So the first line treatment, what they always try first, basically is serial casting. So serial casting is what's in this top picture. So they're basically putting a cast on the baby's foot and changing it out every week, and this can last for up to 12 weeks. So basically, they are trying to allow for a gradual change in position over sort of a long period of time to get the foot back into the proper position. So after they're done with the serial casting, the child may be fitted with an orthotic, or commonly they have to wear what's called a Dobbs bar. So a Dobbs bar is that picture, sort of that middle-ish picture of the feet and the two boots, and there's sort of like a bar connecting it. So unfortunately, they have to wear this Dobbs bar apparatus for about 23 hours a day for around 3 months. But then once the 3 months is up, they only have to wear it when sleeping up to about age 3. There is a really high failure rate for treatment for clubfoot, so it's pertinent that parents adhere to the treatment plan and making sure that we teach them the correct ways to use the equipment and what to look out for. Other non-surgical treatments that could be used, especially for less severe cases of clubfoot, are things like physical therapy, where they're using kinesiology tape to put it into the correct position. Also physical therapy where they're using massage that can be taught to the parents to do at home as well, like manual stretching and massage exercises. Also serial splinting, which is similar to the serial casting. It's just a splint instead of a cast. Um, there are surgical treatments when the non-surgical methods fail. So if they've tried the serial casting and maybe some of these other ones as well, and the clubfoot is not corrected, they could move to surgery, where they could be doing things like soft tissue release. Typically, the Achilles tendon is very tight, so they could be releasing that. They can do tendon transfers, where basically they're moving the insertion spot of different tendons to different areas to help make them not as tight. Releasing tight muscles and aligning bone fragments that may be misaligned. Hip dysplasia, also called developmental dysplasia of the hip, can be congenital or it can also be caused by in utero positioning. There are risk factors for this, being the firstborn child to the mother, being female, being breech, a small petite mother, family history, neuromuscular disorders, and actually being born in winter, which is quite bizarre. Neuromuscular conditions can cause gradual development of hip dysplasia, so it might not be right when the baby is born. Um, Signs and symptoms, the baby may have limited hip abduction and asymmetrical thigh skin folds. So there's not really a picture of this on your slide, but if you are looking at the baby's thighs, sometimes, especially when you flip them over and even look at their sort of rolls on the back of their thighs, the rolls aren't the same. So they're not going to be symmetrical on each leg where their rolls are, basically. Treatment for this, the number one treatment is the Pavlik harness. So the Pavlik harness is the picture of the baby on the top here and that pink harness. So it's an abduction brace that helps keep the hips abducted. We can also use branch traction, which is a specific type of traction where the extremity or extremities are suspended. With branch traction, this one we want the child or baby's hips to be lifted slightly off the bed. So this is sort of similar to that other picture of traction also that had a baby in it. We want their hips to be at about a 90-degree angle. The head of the bed on this needs to be flat, or basically they are going to be like tacoed. They can also use the Spica cast for this, and they can also use surgery if these other methods fail. Septic arthritis and osteomyelitis of the hip. So what this is inflammation of the bone that's usually caused by Staph aureus, and this is an orthopedic emergency. Any delay in diagnosing this can cause severe deformity of the hip or even death. This doesn't necessarily have to always be Staph aureus, and it doesn't necessarily always have to be the hip. These are just the most common organism and the most common location in children. So the child may have had an antecedent illness weeks before they start to have these symptoms that we're going to talk about. So for example, they could have had something like strep throat or an ear infection before. Signs and symptoms in an infant. They may be irritable. They might not want to eat. Their hip is abducted, so moved away from the body and externally rotated. So if you can picture one of their hips basically being like opened up. Pain with any range of motion of the hip, erythema, edema, low fever, and sometimes a normal CBC. With older children, they could be limping, refusing to bear weight on the affected leg or hip. They could have a history of trauma to that hip or leg, surgery, or another infection. Their hip's going to be abnormal. It's also going to be abducted and or externally rotated, could also be flexed. They are also going to have pain with range of motion, especially with internal rotation of the hip. Probably have a fever and positive leukocytosis on their CBC. So treatment for this is an emergency incision and drainage that is repeated every 1 to 3 days. They're also going to be on long-term IV antibiotics, so antibiotics for 3 to 12 weeks. So they are going to be hospitalized for some time. They also could have a PICC line inserted and possibly go home and then have a nurse come to their house to give them their antibiotics near the end of the treatment, kind of just depends. But the prognosis is determined by how old they are when they get this osteomyelitis, where is the site of the initial infection, how long was the diagnosis delayed, and what specific organism was present. Scoliosis is idiopathic curvature of the spine. It's idiopathic in origin, meaning it occurs for no known reason. There's 3 different types based on the child's age. So congenital scoliosis occurs before 6 months of age. It can be genetic or caused by uterine positioning. It is pretty rare, but the left side is more common. Treatment for this consists of bracing, casting, surgical rods, or spinal fusion. Juvenile or early onset scoliosis is diagnosed before age 10. This one tends to be right-sided. So if you look at this diagram of the person, it's a good example. So this one would be right-sided, and this person has a characteristic rib hump on the forward bend test. So you can see that on this person's right side, asymmetrical shoulder height, and asymmetrical pelvis. And also they can have decreased range of motion of the upper trunk. Treatment, depending on the severity of it, could consist of just observing it. They could have to wear a brace like is in this bottom picture. Also could have surgical rods placed or spinal fusion. Adolescent idiopathic scoliosis is the most common type. It affects children ages 9 through adulthood. This one, bracing can lessen the curve progression through puberty. So say if this child is 9 when they're diagnosed with this, if they wear the brace, it could basically lessen the chances of it getting worse as the child grows. If the curve is more than 45 degrees, surgical correction is recommended. Juvenile idiopathic arthritis, also called JIA. It's a common diagnosis for pain and inflammation in joints that can occur as early as age 2. It commonly affects knees, ankles, and hips, and it's usually bilateral. This is caused by a genetic condition. So there's multiple genes that cause inflammation and an immune response in these children. They may also have a rash, enlarged lymph nodes, and an enlarged spleen and liver. Testing for this, there's several different blood tests, as you can see here listed, that can be conducted. We also want to monitor for nutrition deficits, inflammation of the iris called uveitis, growth delay, and psychological concerns from having such severe pain at such a young age. Treatment for this, we can control pain and inflammation with things like naproxen and methotrexate. We can also apply warm compresses. They could also be prescribed glucocorticoids or biological agents like Humira. We also want to preserve function, so they may be prescribed physical therapy and be given range of motion exercises. They could also have surgery on their joints, have to wear splints, and it's also recommended to preserve function that they do low impact exercises, so things like swimming. We also want to promote growth and development and psychological well-being. Osteogenesis imperfecta is also called brittle bone disease. It's an inherited disorder that results from a collagen defect or a dominant gene mutation, although there are some children diagnosed with OI who have no known hereditary linkage. It is classified by types 1 through 5 based on severity. So sometimes with these children, when they are born, they have fractures of the shoulder, humerus, clavicle, or femur, commonly occurring at birth. They also may have multiple fractures of the long bones multiple times, often in short periods. So say the child breaks their tibia, you think it heals, and then a couple months later, they break it again. This can lead to growth plate deformities or bowing of the bones. They may also have a blue sclera, like as shown in this picture, dental abnormalities, skull deformities, heart defects, and hearing loss. This can be diagnosed in utero by ultrasound if it's one of the more severe types, where they can see on ultrasound that there's bowing of the bones or unusual shortness of the long bones. Interventions, we need to be careful when we're taking blood pressure and repositioning. With the automatic blood pressure machines, they can actually injure the child. We need to alert other staff to prevent injury. Fall prevention is a big one, so making sure that they don't get hurt while in the hospital and at home. And gentle holding. Some other treatments can be things like growth hormone and biophosphates. Examples of biphosphates are Fosamax and Actonel. They also may need things like braces, wheelchairs, and surgical rod placement for bones that they have broken several times. Sports-related injuries are very common in children. There's 3.5 million sports-related injuries that occur each year in children 14 and younger. Commonly, these are things like sprains and strains, dislocations and subluxations, tears, fractures, hematomas, and overuse injuries. So usually with these sports-related injuries, they'll present with swelling, pain, and bruising. With dislocations and subluxations, the mechanism of injury is hyperextension or pulling, which then causes pain and swelling. So one of the most common dislocation injuries in toddlers is called nursemaid's elbow, where the radial head subluxation from pulling. So you may have heard about this or had a child with this before if you have kids. Common when kids are playing with each other, brothers and sisters or whoever, and they're pulling on each other's arms, swinging around or whatever they're doing, and it actually dislocates their elbow. Some dislocations may require sedation to be relocated. Surgical intervention could be required for repeated dislocations or subluxations. Tears and contusions. So the mechanism of injury is a twisting injury when the body is planted. So the person, the child, the patient may hear or feel an actual pop. This one usually has conservative treatment where they have crutches or they have braces to protect the extremity and allow it to heal. They could possibly also need surgical intervention. It just depends on where it is and what it is. Overuse injuries. This is where the activity level exceeds the body's ability to recover from repetitive forces. It's more common in things like pitching, tennis, diving, and gymnastics. So we basically want to focus on prevention with overuse injuries and make sure that it doesn't happen. So preventing with proper stretching before working out or playing, cooling down afterwards, wearing proper fitting equipment and shoes, proper coaching, correct body mechanics for the specific sport that they're playing, build up their exercise level gradually, get a pre-season physical, and know their body's limits and don't play if they're already excessively tired or if they're already in pain.